Welcome to our 988 live event. And tonight we're talking about what is 988 when clergy are involved. We have some special guests returning from a few months ago, and we have two special clergy that will start this session off with a small blessing. So we'll invite Rabbi Kline and Reverend Sparks. Somehow I'm going to have to figure out how Reverend Sparks can get on by himself. Reverend Sparks, can you get there we go. So we'll start with a blessing for our world and for this meeting and a mission, and we'll then get into our session. So Reverend Sparks, if you would go first with a blessing.
Okay. To a gracious and wise God who sees our faults as well as our needs, and one who sees devastation and horrific events, that we can rely on him in the midst of difficult times and situations. And even as we talk about mental health, that while we may not always understand, there's someone we can trust in that's way beyond our understanding. And so I'm asking that you would be in this conversation. I'm asking that you would guide us and direct us and meet the needs of people. For we ask this in your name. Amen.
Amen. Amen. Thank you, Reverend Sparks. Rabbi Kline, would you also say a blessing over our world in this meeting?
In addition to echoing everything that my dear friend Reverend Sparks just said, I would ask God to remind us that we are on the cusp of something new and something bold. We ask for the strength, the courage, and the love to look beyond ourselves to the needs of the so many who have been ignored and maltreated in this world, to find a day where we can be Am Echad Im Lev Echad, one people, one heart, sharing an intention to make each of us more whole and more healthy. Amen.
Amen. Amen. Thank you. Reverend Sparks, I think we're going to keep you on because it's a question of getting you on and off. Rabbi Kline, we will see you in just a little bit. Thank you. So to begin, we're going to bring two of our former guests on, Dr. Calvin Chatlos and Dr. Olivia Johnson. Thank you for coming back. And we're going to start off with Dr. Johnson to just give us a brief. There are a lot of people who don't know about 988. So first, what is 988? And I will always remember one of your messages was about empathy. So kind of reiterate how you boil down your personal care and mission and message. So please, what is 988?
So 988 is just a 3-digit number that replaces the former 10-digit number that was the National Suicide Lifeline, right? That even for me was hard to remember. So 988 is our new number. And it really is, it's a talk, text, or chat. And it is actually the text and chat line is, you can send hope. I believe you can send life as well to 741-741. But the 988 number is really just the new lifeline number. You're going to get a compassionate, trained individual. And when you call in, it is a confidential 24/7 number, plain and simple.
Yes, excellent. So, 988 is in its first year. And we have a long way to go, not just in New Jersey, which we will talk a little bit about, but across the nation. And so, we're in the beginning. And what we're going to boldly do is see how we can include clergy into that whole crisis piece. Would you just also briefly comment, because it did stand out when you used the word empathy. You kind of summed up last session with what you really believed in, that when we get calls before crisis, after crisis, during crisis, what was your message about empathy?
Yeah, I just think it's, something that we need to be thinking about. People in times of crisis need us just to care, and we need to be empathetic. And, I think when we deal with people in their worst times or just, having a bad day, I treat people as if they're my family member, right? As if they were my child, and I protect them like that. And we just need to think of it in that way. And when we extend that empathy to them, they know that we have their best interest at hand. And I think when you treat people in that way, they know that. And in turn, they reciprocate the fact that they're going to allow us to take care of them. And it's so important when we do that to people. And, and just that little interaction with them can change the entire outcome of the situation. When you talk about de-escalating something and calming someone down, it's really that simple. It's a human thing, right? It's really that simple.
It is. And it's coming from a former police officer, Dr. Johnson, and an Air Force veteran, as well as the founder of Blue Wall Institute. So, you have wide and deep, long background to boil it down to something so simple and so powerful. So thank you for being here.
Thank you.
Before you go, along the way this year, we did come up together with the acronym AWARE, AWARE. Would you just comment on what that is and how we might offer that to first responders?
Yeah. Are we aware of religious experience, right? And we've talked about this on several occasions. And I think a couple of the things that we talked about are, could it be beneficial of having clergy members even respond on scene if someone were to request that? Now, could that happen? Possibly, depending on the time of day, and could someone, ask for their clergy member? Sure. And is it something that we could do? Absolutely. If it's beneficial and it's possible, I think so. I think it's something that we definitely need to consider, especially if we can maybe avoid a major crisis or someone actually being hospitalized. Absolutely. I think we should consider it. And I think that, clergy members oftentimes actually do ride-alongs when they come to the agency as well. We have clergy members that are sometimes sworn even in the agency. I don't think this is a far stretch. I think that we need to start considering alternative resources and different methods if we want these things to work. And, I think we also talk that when I see a clergy member, I am a Christian. So when I see someone around or when I'm traveling, I will actually stop and ask them to pray for me. It's not unheard of. Even at my training, if they're on scene, for many of my trainings, I actually have clergy members that show up because of the type of trainings that we do. And I'll ask them to pray over the training itself. So that's not unheard of. It changes the entire feel of the training. So someone coming on scene like that, it will change the entire feel of what's going on scene. So how could it not be beneficial? So I think there's really something to be said about that. And I think it brings awareness not only to the individuals that they're responding to, but to the entire department as a whole.
Excellent. Excellent way to start. Dr. Chatlos, if you would also bridge from, you gave a powerful message at the end of the last session. And so however you'd like to summarize that, but my question is, why do you care about including spiritual competency in 988 training, first responders, screeners? And, as we do this, also introduce yourself. So thank you.
Okay. First of all, thank you for the opportunity to be part of this. I'm Dr. Calvin Chatlos. I'm an addiction psychiatrist and child and adolescent psychiatrist working at Rutgers University in New Jersey. And before I think we want to go much further, it was mentioned that 988 is to replace the suicide hotline, which is the long number. It's also a replacement, an alternative to 911. So often, the 911 call would bring out policemen and a situation that they're not trained for in terms of mental health crises or spiritual crises may end up doing harm, or at least not supporting the person the way Dr. Johnson was just saying in terms of having empathy. Their role is different. So part of 988 is to allow people in crisis, whether it's suicide, whether it's just confusion, whether it's psychosis, strange symptoms, strange experiences, to have someone triage and decide who should they call. Should they call a policeman? Should they call a clergy? Should they call a mental health? Should they call a peer counselor that may be familiar with that situation? Now, why am I interested in spiritual competency? My father was a minister, so I've been with church, with religious organizations, and I'm a psychiatrist. And what I've seen through my years as a psychiatrist is a lot of psychiatrists don't have the religious training, the understanding of spirituality, which is where spiritual competency comes into play. And a lot of clergy need additional mental health training. We're both dealing with the same difficult situations of psychosis, of spiritual experience that may get out of control, of drug use, whatever. And so both sides, we'd like to come together, be available, but have a new level of knowledge that isn't being included in terms of the spiritual competency.
Excellent. Excellent. So we are on a mission to have that included first with our work in New Jersey, and then our hope is across the nation. So thank you. Thank you for that. We'll have you back in a little bit. We're going to be bringing Heather Sims here. So we'll see you in a moment, Dr. Chatlos and Dr. Johnson. Heather. So welcome, Heather. Collaborative Support Network of New Jersey. Thank you so much for being here. You and I met a few months ago, and the beginning was about the law in New Jersey that was signed into legislation in August. So we're going to ask you to start with that right after you introduce yourself and the work you do at CSPNJ.
Thank you, Janet, for this opportunity to join this event. My name is Heather Sims. I'm the Deputy Director of Advocacy and Peer Services with Collaborative Support Programs. We are a statewide peer-led behavioral health agency that has a variety of peer services, wellness respite, which has been discussed in the past, supported housing, community wellness centers, and we also address human rights and advocacy, which is where our involvement came with legislative bill S3929 in New Jersey. I'd also like to say that I'm a person of lived experience and a family member. So this is very near and dear to my heart. And this legislation really is, it extends the time period in New Jersey. It just takes my breath away that it was signed, but it extends the commitment time from 72 hours to 140 hours. So that is 6 days that a person can be held in an emergency room, not receiving any kind of care while they're in trauma. And what we've just heard from others speaking is that empathy, that moment of crisis, having someone there who supports you, who can listen without judgment to hopefully help you through that crisis so you don't need an extended stay. So that is where we're at right now. It has a sunset time of 24 months. So it was a very quick moving bill, and we were able to get in language about the standard of care. So we're now working with Dr. Chatlos and some other individuals really to define what does that look like. We have strong support partners with the ACLU, Disability Rights New Jersey, to hold the state accountable, to really produce the reports on beds to make things available for individuals to get proper care. And it's not just New Jersey. This is happening across the country. We have Kendra's Law in New York. We have October 10th. Ironically, it was National World Health Day, Mental Health Day, and also National Homeless Day, where Governor Newsom signed in new law expanding the commitment that if somebody appeared to be of grave disability, meaning that they couldn't take care of their food due to their mental illness or their housing or substance use, that they could be held coercively. So just really discussing what alternatives do we have? How can we engage our religious communities to be an alternative to forced and coercive treatment?
Well, that's a great way to start, because a lot of people don't know about the law. Literally, I think that's when we were speaking a lot. And I think you did mention, there have been laws even before New Jersey around the country. California has one. I don't know what else, but this really affects every one of us across the country.
Absolutely. The commitment laws, IOC, intensive outpatient commitment, and any national advocacy and rights group that you're going to our conference, this is the discussion. What are our alternatives with wellness respite, reaching out and building stronger communities, addressing employment, education, social determinants of health, and really being compassionate with individuals?
So that gets into me. I start leaning into the spiritual and cultural competency of what's required to go from what might have been a historical reaction. Somebody's in crisis, we drive them right to the hospital. Tell us a little bit about the alternatives that if the 988 callers, dispatchers, responders knew that the peer respites in New Jersey are available for certain people who qualify. Tell us about the peer respites, because many of us would have liked to know that exists.
Oh, absolutely. And they are a great resource. I know recently, over the past 3 months, we've been above 90% occupancy. These are where a person can go in a safe environment. It is a house-like setting, no more than 5 individuals. You stay for 10 days and you work on wellness goals that you identify to decrease that current crisis, so you can remain in your community, going to work, going to school. But the problem is we only have 3 in the state of New Jersey that are peer-led. And we need to address that. There's nothing here in South Jersey. And how do we expand those services? So every human, though, if they're experiencing some kind of crisis, has a safe place to go for a short period of time and stay active in their community, and they're driving the supports that they need and how they want to address that.
Exactly. And, just to go a few more steps, because I think it's really important for viewers to know peer respites exist around the country. We have a post here. The National Empowerment Center online will list all the peer respites around the country. And we have 3 of them right here in New Jersey. I worked at Rutgers University, and I've spoken to various professionals there. They're not fully aware that some of their students go to the peer respite in New Brunswick as an alternative to either going home or going in a hospital. So, and
that's kind of the point. If they're not aware that individual's life might have had any kind of disruption, then something's working. There was a safe place for someone to go. Hopefully they're aware that they're out there to refer them, but it doesn't interrupt somebody's life and what they're working towards.
Yes. And I'll just give a little tidbit of what I just picked up. We're talking with some of the professionals at Rutgers. There is now, I don't know what it's called, a facility on campus for students in recovery. And instead of having to go home and get well, they're actually allowed to stay on campus and continue work, which is part of the recovery, right? That they continue school. And their vision is to have one for mental health as well, which is fabulous. So it's like, I'm almost saying a partnership between peer respites and what some of our colleges can offer students. Would you close with, I share this vision that we would love to see a peer respite in every county in New Jersey, as well as every state across the nation.
Oh, absolutely. I mean, you look at just the fact of that they're almost at 100% occupancy rate. And this is a place where someone can go again and get that help. And right now, we already have access to treatment problems. We have an increase in individuals experiencing mental health crisis, increased use of substance abuse post-COVID. So if we had one in every community, think about how many individuals and the cost savings for an individual to go to a respite compared to a state psychiatric hospital or any other kind of long-term institution. Not only the cost of care, but the cost to that individual not participating in their community and looking at the big picture and the meaning what respites could do for that.
So closing thought on that, just give us some general figures. What does it cost to stay in a peer respite compared to a state hospital? Just general. So
I'm not a numbers person, but per day, if I'm just calling off of some of the past testimony that we've provided, advocating for more. So the cost would be about $270 a day for a peer-run respite, where someone's only going to stay for 10 days, compared to $1,000 to $1,500 a day, and that's probably very low for a state psychiatric hospital.
Yeah, so we can add the numbers up and see how that can not only save money. I mean, that's kind of an obvious one, but it saves the stigma for that person. You know, the individual walking around with the stigma of I was labeled and I was put in a hospital. And then the stigma of the community who knows that that person was put in a hospital. There's a lot of shame associated with that. So thank you so much, CSB&J and the peer respites around the country. We're going to bring Dr. Chatlos in and have some commentary on, you know, what do you see now as the value? Because I think you just became aware of the peer respites around, you know, right outside your office. As you see patients, you now know you can refer there. And then also comment on why is it important to get more detailed about the standard of care if they have to go into an ER or a hospital. So first, peer respites. What did that do for you in your practice?
There are a lot of cases, as have already been mentioned, that don't need to be in a hospital, and they don't need that kind of care, and they may even be harmed by going into that stigmatizing setting. And that's where peer respite can look at it, can be more compassionate, can have more empathy, and provide different services than are going to happen at a hospital. So let me go into the next question, Jan. Commitment for 3 or 6 days. I can understand how we like to protect the public if there is a danger to themselves or others. However, right now, the standard of care in an emergency room doesn't even include the mental health professional asking themselves, are we aware of religious experience? Mm. Over 85% of Americans themselves in studies have shown and identified themselves as having significant either religious or spiritual connections, the majority of the population. And if that standard of care doesn't even include that, there's a high likelihood that a diagnosis will be missed, a spiritual experience will be misdiagnosed, medications will be given, and the medications will sedate the person so they can't even explain what really may be going on. Mm. Extending that mistake to 6 days is what we're concerned with. And that's why Heather's trying to get a standard of care that, first of all, includes, are we aware of religious experience? Mm-hmm. But in most ERs, those 3 days, just medicate and stick in a back room. Mm. And don't even see the psychiatrist for more than a few minutes. And that's it. We're concerned that add 3 more days and it's not very good. So if we're going to extend it for 6 days, what are we actually going to be doing in asking the questions, doing the evaluation and intervening so that it is not only the dictum in medicine, first do no harm. We definitely want that to be present as a standard of care. And then what else can we provide? The patients we're talking about, whether it's a spiritual experience or a mental health experience, they're in crisis. It's going to be intense. And it's not going to be clear cut as to, is it spiritual or is it a mental health crisis? That the content may be similar, but the way it presents is very different. Someone in a spiritual experience with a spiritual crisis or spiritual emergency is going to be more connected and maintain more of a connection with reality and be able to carry on a different type of conversation. Someone in a mental health crisis may be psychosis. It may be delusional. There may be hallucinations. And we haven't even said much. There may be drugs involved.
Mm-hmm.
And that also, the place for drug experiences may not also be in an ER, medicated, and given a diagnosis of a mental disorder. So the mental health experiences and crises look different. We hope that our 988 triage and the people in the emergency room with a different standard of care will very clearly separate, or at least try to separate. Is it a spiritual crisis? Is it mental health? Is it in between? Is it drug? And then ask for the right complement of people to go out there. Does it need police? Does it need a peer with a similar experience, especially if it's a drug experience? Does it need a clergyman? Does it need a mental health worker that can make a diagnosis? And that's really what 988 is about. We don't just immediately call the police, we assess, but without including what we call non-ordinary experiences of spiritual experiences, psychosis, extreme states from meditation, drug events that may be similar, we're likely to make a mistake. So that's why I think, Heather, I think your idea of getting the standard of care, at least in the bill, and now working on it, because there has been no standard of care really spelled out for that 3-day commitment. And so I am glad to work with you on that, see what we can do.
Absolutely.
That answers your question, Janet.
Yeah, no, I'm glad that we have all this. You know, we are talking about 988. We're talking about one, it's new. So we're looking to influence the training that it can include spiritual and cultural competency, and it can include alternatives. So there's some simple things we want to just include so that the individual and the community see some other routes. And, you know, some of our assumptions are built on it sure could be healthier for a person to be treated for a spiritual issue, if that's what it is, or go to a peer respite, than always be put right into the hospital with only medication. So as we go forward, let's see how much further we can get on the standard of care. We're going to move on and add our clergy in. And Calvin, as Reverend Sparks comes on and Rabbi Kline, comment a little bit about, you know, imagine if you were a psychiatrist on the ER or on the psych ward, what could you imagine the partnership with clergy? So kind of think about that or comment, and we're going to ask Reverend Sparks to also come on.
Do you want me to say something while you're bringing them on? Yeah. First of all, we hope that whoever is in the hospital or in the emergency room representing the mental health system has an understanding of has a spiritual competency to know that maybe a clergy might be useful. Maybe a peer counselor might be useful more than just quickly prescribing a medication and calming the person down. We can calm the person down with a hand, with words, with empathy, with compassion. It doesn't have to be medication, but we hope the mental health professional has that knowledge.
Absolutely. So, you know, kind of connecting into, and we're still hoping Reverend Sparks can find his way in. Rabbi Kline, you have, and Heather, we'll have you come back. Maybe that'll make it easier for Reverend Sparks. So, oh, here we go. Then I'm going to start with Reverend Sparks, because you have invested in crisis intervention team training with a clear commitment to work on the crisis part, prevention. Would you please introduce yourself and then talk a little bit about how this all fits into helping 988?
I'm Reverend Ronald Sparks. I'm the pastor of Bethel AME Church in Freehold, New Jersey. As a chaplain, I'm a chaplain for the Monmouth County Sheriff's Office as well as the prosecution office. And one of the benefits, I was allowed to take this crisis intervention team training. I thought it was important because, as Dr. Chatlos said, that we need to be educated. I think there's an assumption that we're not taking, but others may, that we know how the mental health system's supposed to work. We know how clergy is supposed to work, and we know how the medical field is supposed to work. We don't talk about how we bring all of those groups together. But there's an education that's on the part of each of those groups to try to understand the value of each one of those foundations to help people to be able to get better. While we can talk about spiritual, we have to move beyond that when we're dealing in the community. And as a chaplain, I have to take my pastor hat off, and I become more of a community person. And I become what that person needs. So the more educated I am, the better I can help facilitate that. So when you talk about 988, in order to make the appropriate decision as to who should be there, you need competent persons to show up. As I tell Dr. Child, prayer always works, but there's some other things we may need to do in addition to that. And so we need to be educated enough to recognize either this is not my field, I will pray and be a presence for the individual to keep them comfortable, or I can say, I sort of understand what's going on. Can we work this out? So I think it's going to take time for us to try to figure this out, because this is new. This is groundbreaking to, be able to come together and try to decide who should be on these calls when this crisis comes.
You had mentioned, just so that we take a little more from your thought and then hear Rabbi Kline's thought as well. When we spoke before, and because you're also on the team, you're on a crisis intervention team, so you may actually be called on that team, or you may called because you're a pastor. And if I'm in your congregation, I might say, please call Reverend Sparks first, before you do anything. I'd like him to show up. You had talked about one, I think the words you used is you want to be able to walk with the person. So let's say it's somebody in your congregation or your community. What does that mean to walk with a person through this crisis, through going into an ER, through the experience of a hospital maybe? What's the walking as a pastor?
I think the first thing we have to understand is what is our role in that moment. And once we understand what that role is, we may have to defer. But while we defer, maybe like to a Dr. Chatlos, or maybe it's the crisis intervention person, maybe it's the police. We have to defer, but this does not mean we leave. It does not mean we just disappear and say, okay, they got it. Call me when you're done. It's we figure out where they're going, what's about to happen to them. That may be reassuring to talk with the family. This is the process. This is what's going to happen. This is what we can expect. I will try to get to the hospital to see what I'm able to do, as I may have a little more credentials than the average pastor. So I may get to do a little bit more than the average pastor. One, because I'm a chaplain. Two, because I am CIT trained. So that might give me an entree to get some information, or at least be in the area. And I can keep that family, be a bridge between the family and the crisis team, to let them know their loved one is okay. I've seen situations where loved ones cannot go. Loved ones have to wait in the waiting room or go home. They don't get to hear what's happening or what's going on. And so to have a comfort of someone, informing them, telling what's happening, making sure that their loved one is okay. I think that's part of that walking, that process, so that they don't feel like they're alone and they're left out.
Yeah, that means so much. Doctor, before we bring Rabbi Kline on, Dr. Chatlos, could you comment again, kind of connecting if, Reverend Sparks showed up and you are, the psychiatrist on call and you're going through the whole scenario. What would it be like for you to have a Reverend Sparks also at your access or seeing your potential patient have access? What is that? What would go off for you, or how would you deal with that?
I'd like to start with, if I ever have something and need to be taken to the emergency room, Reverend Sparks, I would like you to be with me.
Please.
Marc taught me well. Rabbi Kline taught me well.
Reverend Sparks, you just described exactly what we need. People, parishioners, even common citizens get to an emergency room. They don't know their rights. They don't know the system. And just having someone there to be supportive, maybe speak up for them a little bit, but just so they're not alone, makes a huge difference. For me, if I were there, I frequently, when I work in the hospital, I may work with the chaplain very readily, because I at least am tuned into the possibility of spiritual experience. One of the things, though, by the time a patient gets to the emergency room, unfortunately, they're almost going to have to ask for a clergy or ask for a peer, which is rare. So I would have to speak more with Reverend Sparks as to how his role really fits on a day-to-day, on an encounter basis with the CIT, with the community team, because I'm not familiar with it. We don't have it as well developed as yours is down in Freehold. But Janet, that's part of what we're trying to get. We hope to get the mental health professionals, whether it's a psychiatrist or the screeners or the worker doing the assessment, to at least know that there's something else that may be able to be brought in that might make a difference. And we don't have to automatically sedate and drug and wait for 3 days.
I'm going to make
Reverend Sparks, when I'm hospitalized,
we're calling you.
Okay.
So I'm going to have you, Reverend Sparks, to hold your comment and come in after Rabbi Kline. And Rabbi Kline, if you would also introduce yourself, where you're from. But the bridge I'm seeing here is that you were a hospital chaplain. And from our conversations over the years, you are very familiar with spiritual crisis and spiritual emergency. So first introduce yourself, and then maybe even pick up on, what was your role and what do you think the role needs to be with the hospital chaplain, and then expand it to, your work as a rabbi.
I'm Marc Kline. I'm currently serving as the interim rabbi at Temple Oho Shalom in Harrisburg, Pennsylvania. I thought I was done with the pulpit rabbinate, and then Einstein says coincidence is God's way of remaining anonymous, and a whole host of things happened, and here I am doing 3 years to rebuild a community. And while I was in New Jersey for 8 years, I really had the blessing and privilege of working with Ron Sparks, dear brother, and I miss him. So, Ron, thanks for your accolades, but also thanks for all the stuff you've added to my world. Appreciate it. In my entire career, going back to rabbinical school, I've been involved in chaplaincy. I was chaplain at a Jewish nursing home in Cincinnati, and I've helped start 3 police chaplaincy teams, one with the prosecutor's office in Monmouth County with Reverend Sparks. I served as the chair of the chaplaincy board at a Catholic hospital in Lexington, Kentucky. So I've spent most of my career doing the work of trying to take care of people. And there's a couple of things that I think require some clarification. There's a huge difference between religious and spiritual. And a lot of clergy walk in armed with religious stuff. And I'm not sure that that's always relevant to someone in crisis. But faith and spirituality is really the more universal piece. And certainly as a chaplain, when I walk into a situation, I'm not a rabbi. I'm whoever that person needs me to be. And not all clergy are prepared to be able to do that. So what's at stake is the ability to look at someone from that position of empathy and compassion and competency, to remember that it's not about what I think or I see from my perspective, but being able to empathize with the person who's in crisis and to help in their care. You know, Dr. Chatlos, you used the word triage earlier. And the real purpose of triage isn't to get a body from here to here. It's to assess what's really happening so you can appropriately treat. Well, most hospitals aren't equipped to treat a spiritual crisis. There may or may not be a chaplain on staff. And the hospitals that used to run chaplaincy training programs don't, because there's no profit margin there. And so the moment that someone gets to an emergency room, you really do have to become very proactive, either as the patient or as the family, or I would pray as the medical caregiver, to know that, you know, the medical caregiver may not be competent to deal with some things that present. So when Reverend Sparks says, you know, sometimes we have to get out of the way because it's beyond our competency, that applies to the medical field as well. And to not just impose that we know what's best for you. And in this world where the ERs continue to just be over full, it's real almost too easy to throw medicine here and medicine here, medicine here, because I've got 5 other people waiting to be seen. So this is a spiritual healthcare crisis, but it's a healthcare crisis. And overburdening a system to the point where I would argue that some hospitals commit malpractice. So it's not just they missed something, but it may be actual medical malpractice to diagnose and treat something that doesn't exist. You can't say anybody that shows up with a headache has a brain tumor. And unfortunately, that's what too often happens when we're talking about the unknown. Before COVID, before we knew what COVID was, I had it. My doctors all now tell me I had breathing problems. I was sicker than I'd ever been. And the first doctor I saw told me I had lung cancer. The second doctor told me I had COPD. The third doctor told me it was because I was overweight. And I said to him, I was overweight 4 weeks ago and I wasn't sick. You know, now after the fact, we know what it was, but the fact that they hadn't heard of it meant it didn't matter. The fact that I presented with different symptoms didn't matter. And certainly the physical, it's easy to hear that I can't breathe. But when someone is incoherent, or what we would say in a mental health field, delirious, we would assume that they've gone into a state where they need medical care, when the reality is that for so many people, some trauma has happened or something has entered their experience that has created a spiritual crisis where God is an issue, where my faith and everything I've stood for is an issue. And you can't treat that medically. And so, you know, this is a cutting edge conversation, but it really shouldn't be. Back when I was in rabbinical school and I was chaplain at the nursing home, I was part of what we called the Eden Alternative. And we were experimenting back then. This is 1990, between 90 and 95, bringing animals into hospitals and into nursing home settings to replace medication. Petting a dog, you didn't need to give anxiety medicine. For people who were having issues in terms of memory loss or cognitive loss, you put a bird cage and a bird in their room, and they had to be reminded by the tweet of the bird to give the food or to change the paper. And people stayed cognitive a whole lot longer and a whole lot stronger. So I'm not sure why knowing that happened, why we got rid of it to some extent and went back to medicate everybody. It's kind of like I learned a little while ago that we had electric cars in the 1890s. Okay, and we got rid of it. Now all of a sudden we have electric cars again, as if it's some new technology that didn't exist before. So it's out there, and we know it's real. And so many people proclaim to be people of faith, and yet we ignore the fact that faith can be traumatic. Jacob wrestles with the angel and wrenches his hip. That's in any event. I apologize for going off, but training is everything, and not like if you go into a psych ward in a hospital, they don't get chaplaincy care most of the time, because many of the chaplains, they may be equipped to be chaplains, but they don't know what to do when they walk in to talk to somebody.
Yeah.
So 988 is a huge step forward, and unfortunately, it's met with legislation that is a huge step backwards.
So we have the legislation, and we have 988. We want to connect some of the dots of what's been said, that clergy being on the scene or available to be called in can be helpful. Standard of care that includes spiritual and cultural competency, if the person's brought to the ER, also would be very powerful. Education for both clergy and the medical needs to include what is already in what we call the Psychiatrist Bible, the DSM. Dr. Chatlos, if you would just give that bit of education awareness on the V code of spiritual and religious problems. It is in the DSM since 1994. And how does that come into training and awareness for both clergy and medical? Because it's specifically in the Diagnostic Statistical Manual.
It is in there, but you're hitting at one of my sensitive areas. The DSM is almost bereft of spiritual ideas, spiritual experience. They don't define it. They don't talk about spiritual crises, spiritual emergency. The only mention really of spirituality is in something called the V code, which isn't a diagnostic code. It is a condition for attention. So it doesn't get reimbursed, but it may, if it were used, highlight to the professionals that this is an area that is important in the clinical care. Let's pay attention to it. However, Janet, I don't know of too many medical schools or training programs or even psychiatry training programs that say much about it or mention it, which is why we're so interested in getting spiritual competency into the medical profession, into the psychiatric profession. But it's there in the DSM if we as mental health professionals know about it and would include it, because, as I said, it sends a message to the next provider. Please pay attention to this. We think it's important.
Exactly. And I know you have a vision on, if we're still going to continue to use the DSM, you have a vision going forward of what you'd like to see.
Yes, the DSM-6 is going to prioritize the role of spiritual experience in mental health care because, as I said, 85% of American adults are spiritual or religious. It is important, and we at least need to put it in with all of our other biopsychosocial diagnostic understandings. And I think we now know enough about spiritual experience, even how to promote it, how to understand it, how to deal with it, that it's time that we ask psychiatry to move forward with this.
Excellent.
Yeah, that's my beef.
Yeah.
Dad,
Yes.
part of that,
Rabbi.
asking psychiatry, we also have to realize that the people who would bring patients to places, the police, EMTs, need this training as well. One of the things I love, Red Bank Police Department, Red Bank in New Jersey, they're working on arresting second, treating first. So if they find someone in the streets that they're assuming is a drug induced coma or alcohol, etc., their first move is to seek treatment before they seek jail or incarceration at a hospital, because it's a commitment is an incarceration. So while we're training the people in the mental health field, we also have to make sure that that training goes to the people who present patients to the mental health field, and it's out there. And the Red Bank Police Department, I think, is really doing a great job experimenting on how to handle people in a more holistic way.
That's great news. It's one town, one person at a time, one town at a time, one state, one country. Reverend Sparks, you went through crisis intervention training, and at this point, cultural competency has become more popular, aware, it's included in that kind of training. My assumption is spiritual competency is connected right there. But could you comment on to what extent, like, what does cultural competency do for you as a crisis intervention team member? We'll start there. Yeah.
I think we have to be aware that there are certain ethnic groups that when you're talking a mental health crisis, there's a stigma. And so some of that will be hidden. Some of it will be downplayed. They're not going to want to call anybody because they want to try to keep it held within. And so understanding that that is an issue with culture, somehow we have to break through to them to earn their trust, to recognize that, we want to help, not hurt. And that's where the trust comes in with beyond law enforcement, not just Jewish rabbis, not just Christian pastors. We got to go across the gamut of religious leaders who are willing to accept the fact that there are times that crisis is going to happen, and it's going to go beyond your understanding of your culture. And you have to be transparent enough and vulnerable enough to be willing to go through that, recognizing that you could get backlash in your own community. And so therefore, the police officers, as Rabbi Kline talked about, there's a movement of the chiefs to send more officers to CIT training to help them with the mental health aspect. But the religious crisis is nowhere to be found in that, except for the fact that I'm there. So I represent a chaplaincy component, but it's not talked about as a spiritual crisis. It's to help, help de-escalate, help calm the situation, but not necessarily deal with that part of the crisis. And so when we talk about competency, I think we got to become vulnerable enough to allow ourselves to realize that people are more important than sometimes even our culture, in the sense of making sure that they get help, not turning your back on your culture or any of that, not everything that you've been taught to throw it away. It's, I have a person in front of me that's not what I normally see, and how do I help them through that rather than push them away? Because that does the same thing that you're fighting against. Instead of them putting them in a hospital and committing them, they're pushing them inside of their culture and community, and they can't get the help that they need. And so I think that's the same as we talk about the disciplines of learning the spiritual aspect, learning the medical aspect, learning the psychiatry aspect of it. We also have to look at the culture aspect of it, and what do they go through. If I were to say I'm in crisis, what does that mean? What dominoes have to fall for me to get the real help that I need?
Exactly. I'm going to.
Janet,
Yeah, go ahead.
could I interrupt and add something?
Yeah.
there was something, Rabbi, that you said. You mentioned trauma. One of the things that almost all people that come to the emergency room, actually maybe all people in life, we have trauma in our life. And the way we learn to handle trauma is it can be handled through mental health care, and it can be handled through spiritual care. So that identifying trauma and cultural, different cultures handle trauma differently. So I'm just underlining, Rabbi, I think part of the training of EMTs, of emergency room workers, of mental health workers, trauma is one of the things that is so common, leads to crises, and actually bridges both mental health and spiritual care.
And Dr. Chatlos, I absolutely agree, and it's the root of everything, obviously. But one of the things that we also don't talk about is how do we find out what the root of that trauma is? We don't investigate, we don't ask questions, we treat. We don't invest ourselves in the patient, and that's challenging, because if we don't seek information, then there's no way to competently help. And that's where malpractice begins, is deciding what I think your trauma is. So it begins with trying to figure out what the root of the trauma is. And, when someone's telling you something, you can't just dismiss it because you think they're drunk, and that all too often happens. Some of the ride-alongs that I know Reverend Sparks and I have been on, there's a presumption that what we're seeing is the only possible answer because that's what we've been trained to see. And that's not healthcare.
We need a full day to cover all of these pieces, but tonight was really about opening up the conversation on 988 training, making the audience more aware of alternatives to hospital, looking at, we are building a standard of care that if we have to go to the hospital, it's much more respectful and dignified. But also, how do we include clergy? What is 988 when clergy are involved? Let me ask this question before we bring everyone else back to Reverend Sparks and Rabbi Kline. What do clergy need in the mental health or crisis training? And I know, it covers the gamut from just basic awareness of mental health to really being able to handle a crisis. And Dr. Chatlos, I'm going to ask you to connect into, your history of how your father was trained as a minister in some of this. So Reverend Sparks, first, in general, the broad brush of all clergy, what do you think are some of the basics should be offered around this whole 988, the law, and just the general mental health crisis? What do clergy need in general? What do we need to offer?
Before we offer, the clergy got to be willing to accept what's offered. We're busy. We pastor, we do stuff in the community. You have to set aside time to accept the calling to do. This is a calling, and not everybody will want to take this next step. Once you're willing to do that, it's really about making relationship and connections to learn as much as you can learn. The CIT training is great. It gives you a bunch of information, but Rabbi Kline talked about the empathy. Until you see someone go through a crisis and what they have to go through and what the system takes them through, that's what causes you to want to get more involved and advocate for people. When you see what they have to go through, and you understand why cultures see it as a stigma, because of, we didn't talk about it, but liability plays a lot in this malpractice, as Rabbi Kline talked about, because they want to make sure that they're not held liable. They will do certain things to ensure that they're not held liable. It may not be the best thing, but for them, that's what they need to do. So it's really about, once you accept for what you're wanting to take on this, to learn as much as you can learn, develop as many relationships, talk to as many people, and try to understand what is the process supposed to be. Because once you understand what it's supposed to be, you can't make any suggestions or changes until you know what's supposed to happen, and just care enough that even if I don't know everything, I will love them the best way that I can through this process.
Thank you. Thank you. Thank you, Reverend Sparks. Rabbi Kline, what would you summarize as some things that, if we could offer clergy awareness training or skills competency training, what would you propose the general population across various religions and spiritual practices?
When I was in Lexington and I taught clinical pastoral education at the Lexington Theologic Seminary, Disciples of Christ Seminary, and my goal was always to help clergy and potential clergy get out of their own way, because chaplaincy is about caring for the patient, not bringing your stuff. This isn't an opportunity for evangelical ambulance chasing. And lots of people can walk into a hospital setting and say prayers. Prayer's good. But the chaplain, the clergy, needs to pray that I'm not bringing my baggage into that room, into that setting. And so good CPE training really begins with helping people see past themselves, being able to withdraw their ego, their baggage, the fight they had at home just before going into the setting, and remove all of that. And that takes work. And I think Ron's absolutely right. You've got to want to do it. And unfortunately, too often it takes having experienced it with somebody or yourself before you really understand why it's an essential tool and a necessary service. Yes,
thank you. Yeah, I know, Reverend Sparks, you said this has to be a calling, but in general, my assumption is we are all affected by mental health. And it's almost like every pastor, minister, clergy, parent, doctor, EMT, 988, everybody needs to have some awareness training, and I know a few times, a number of you had used the word empathy, to just have that, to have an awareness of spiritual crises. It almost seems like it's something that we all need to have, even if it's not a calling. We do have.
I can just one thing. Dr. Chatlos said, 90% of the people can claim to be spiritual. Well, faith is about not having the insecurity and the ego. If we really want to affect change, then we need to stop talking so much about religion, or that there is a God. And we need to start talking about how God manifests, which is in the realm of faith, so that when I walk into a setting, it's not about me. And that's whether I am the EMT, whether I'm the person that called 911 or 988 on behalf of someone, so it's really about, let's walk the walk of being people of faith and stop talking about, oh, I'm spiritual, or I'm religious, or I keep kosher, or I do this stuff. I think that's really what's at stake for society.
And Rabbi Kline, you described clinical pastoral education as to get your personal stuff out of the way. I thought you were describing mental health training. We should be taught to do that. And it isn't as much of our education in psychiatry and mental health training as it used to be many, many years ago. And as Janet referred to, 40 years ago, my father is a minister, the medical school for the state, it was in the state of Maryland, every year had a conference specifically for clergy and any religious tradition talking about mental health aspects that they may need for referrals in their congregations. So I didn't realize they were so far ahead of time.
So, I mean, that's just a good example of a medical school or other institutions can offer just a basic orientation. You know, I know Dr. David Lukloff spoke with us about, he did do very specific training for faith-based leaders. So it is available. We want to make it more visible. I'm going to put a question up from the audience and bring Heather back on just this question and see if, you know, Heather, I know you've spoken about a psychiatric advance directives. I never heard of it until this year. I wish I did. So I have you respond first, Heather, and then Dr. Chatlos. And then for the audience, that there is such a thing as psychiatric advance directives. And somebody had mentioned that we could put Call My Clergy in that. So Heather, if you want to comment.
Absolutely. Thank you. So a psychiatric advance directive is a legal document. New Jersey does have a law instituting them. There is a registry. So the psychiatric advance directive is a document that really gives an opportunity for an individual to express how they want to be treated and what care would work best for them. Who are the best supporters, whether it be their mother, their clergy, a treatment provider, whoever that person is, they identify who they don't want, what medications might have worked in the past, what medications haven't, what treatment they would prefer. So not only, you know, please call this person if I'm in crisis, but you know what, maybe I want to go to a wellness respite program, and that would be an alternative. So they are developed by an individual when they're doing well. And it's a document that outlines this. An individual can identify a healthcare proxy, a mental health care proxy, but they do not need to complete this document. It does not have to be notarized. It needs a signature of a witness that's not providing services. And then a person can put this in the New Jersey State Registry. So if you go into a short-term care facility or a state psychiatric hospital, because they're supposed to follow the individual, then your provider can, look that up and see what your preferences are in treatment and who are those supporters you would like involved. And the interesting thing about a psychiatric advance directive is it foregoes HIPAA. So if that legal document says that I want you to call either Rabbi Kline or Reverend Sparks, they don't need a release of information to reach out to that individual because you've already given them permission in this legal document. And I always encourage, when you create one and you're identifying who your supporters are, as they were saying, this is a calling. Somebody has to choose to be there and be present with an individual. So you want to share that information and talk to somebody. And these documents have improved relationships with family members and helped people avoid lengthy psychiatric stays.
Excellent. Thank you. Dr. Chatlos, do you have any comments on how advanced directives are used, applied? Are they being used? You know, is it?
The institution I work for requires us to ask all patients that come in, outpatient, inpatient, do they have it, and encourage them. However, I'm not sure to what degree it is being used. It really is. I find that it's best for patients that start to have repeated problems and are the ones that are most likely to be vulnerable to mishandling as a diagnosis starts, and then the next place just picks it up and then picks it up. And the advance directive helps them have more security and have more agency over their own care, which unfortunately sometimes the system diminishes. So I think it's a good idea. I think it's being widely used because the agency monitors for accrediting require it, but I'm not sure how much it's actually used in emergency rooms, in out calls. I don't know.
I'm going to bring Dr. Olivia Johnson back up, and we'll start to wrap up. But I want to connect this, and Dr. Johnson, if you have an opinion from a former police officer, or you're training police officers. If I get 988 called on me and it happens to be a police officer team versus a crisis mobile intense unit with, I guess, crisis intervention team people, and I say, I do want my clergy, but I don't have an advance directive, what do you think the responses could be from, not listening at all?
Right.
And then I want to lean this back into, and what do we need to do for training in 988? I want to keep coming back to that. So what's the likelihood that if I say, I want, please call my minister, I might even be in somewhat of a psychosis that's just temporary. What's the general likelihood? And then what do we need to go back and do in 988 training for just first responders?
Yeah, I think the likelihood, depending on, again, there's many variables here, because again, the time of day, are they available? Is anyone going to listen to this? I think it's going to be unlikely getting someone there, because again, they're not going to be worried about that in the moment. They're going to make sure that, what kind of, are you stable, or, what's happening in the situation? That's not going to be the top of their list. Just as we talked before, Janet, they're not going to be going, is she having, are we aware, is she having a spiritual experience? That's going to, if they're trained on it, that may be something down the line that they are checking on a protocol, but right off the top of the bat, that's not a safety issue right now that they're thinking about. So that's going to be down the list. So that's not going to be something that's right on the top here. Not that it's not going to happen, and it should be something that they're thinking about, but it's down further on the list. And whether they're going to call clergy or not, probably not. But that's not to say that it can't happen, especially if we're able to stabilize the situation and things are safe. But again, there's so many different things going on here, manpower issues being the top one. And if they're calling 988, and like we talked about before, where Ernie said, 98% of these calls are being handled on the phone, where resources and other things are happening, and they're being able to take care of that. Now, that's still to say, if you're getting 5 million calls, texts, and chats, that's still a lot of calls that aren't being handled on the phone. So we still have people responding. But again, there's so many different variables here, right? But I'm thinking, man, if we can find somebody that can get a resource to someone's chaplain, and I think with time, those things can be handled as an additional resource with 988, that we're not calling out law enforcement for these calls. That may be another thing that we, where 988 may have been failing initially and people didn't want to call, that could be another thing where clergy is plugged in there, and they may be another alternative resource that people can plug into those kind of, resource, components. That would be amazing if that can happen. How quickly that can happen, again, time will tell. But locally, small town, that may happen. People may know those people, and there may be a direct connection. When I worked in a small town, I could have those connections on my cell phone, right? I knew who those people were. Bigger towns, probably not so much. But again, I'm hoping for the best, but whether that's going to happen, I don't know.
Reverend Sparks, I think you mentioned you might have had a class. Can you stay till 7:30, or do you need to?
Oh, no, I'm good.
You're good. Okay. So if you wanted to comment again on, you're coming from the crisis intervention team training. All clergy are not doing that. You did. Do you have any comment to make about, how can we make this more aware, either through, letting people know they can have advance directives and list their clergy, or make it more aware to first responders that clergy are an appropriate source, and to listen to it? Like, if I'm asking for my clergy, how would you respond to how can we wake that up a little more sensitivity at that call time?
I think we have to be involved and inject into the process, even if it's just being on calls, listening, understanding what's happening. Because like Dr. Johnson said, we're not going to be the first persons they think about. They're going to want a mental health crisis person to come out there, assess the situation, and the police, if the police are called, they're going to determine what's the safety. They tell us that as a chaplain. We can't just go. They have to assess the situation, and if we're called, we can come. And so I think it's part of it is injecting those who are willing to be a part of this to learn the system, to learn what needs to happen so they can get in and see where they fit. Everybody may not, mental health may not be for everybody. And so that might not be an area that they want to be called to right away. And so it's really a time of assessment. So as they learn what the process is and should be, the clergy can then make a determination of what is my role or what I see my role as, because you're going to have different levels of wanting to participate. Not every pastor clergy is going to want to participate. However, once they see what the process is, what is it that they're going to actually do? Am I willing to learn that, depending on, how long they've been in ministry, what the age level is, how much energy they have left. A lot of that will determine. So, along with Dr. Johnson, it's you really have to understand what the issues are now. And once you understand that, you will determine where your place will be.
Thank you. You're helping me link a few things together. And Dr. Johnson, the last session, I think you said something about, have that pause in there where we don't immediately react from fear. If I'm first responder, that I do stop reacting from fear and sit back and do that empathy, that listening. So it's such a simple point to make, but that can de-escalate a situation. It can give an option to really hear the person. I remember other first responders were saying, we've seen scenarios, mental health calls where, Jesus and Buddha and Christ is written all over the wall, but they didn't know what that meant. That's probably a bit of an indicator there's some kind of spiritual thing going on. Right. So,
it's uncomfortable, right? It's the idea that we don't like to be uncomfortable. And I always say to myself, and that's with everything. You'll find people that don't like spiders, they don't like snakes. And what's the first inclination? They want to kill it. Right. And so it's just the idea of something that scares us, and it's uncomfortable. And I tell people, how do you think these individuals are feeling? No one wants to be around them. They're scared of them. These individuals are going to be tossed through the system, and they've been uncomfortable for a really long time. And all it takes for us is to spend a little bit of time where they're uncomfortable, is to put ourselves there for a little bit of time, and to really just to be human with them, to give them, like you guys all said, to be empathetic, and to treat them like the humans that they are, right? And what all of you do is to treat them like our family members, right? Like the people that they really are, and that they probably have not been treated like for probably many, many years, because everybody's uncomfortable with them and they avoid them. And that's what we really need to do. And when you start doing that to people, you'll be surprised at what changes in their lives.
That's an excellent point. And I want to make a link to Heather and then bring up a participant comment. Heather, if you would just comment again, what that pause might do, and the awareness that we have peer respites for those 988, the call takers, the screeners, the responders, what happens in that pause, or what do we want the awareness to be around the pause that says, am I aware that there's a peer respite local? Do I have the number? Like, tell us a little bit more. What's that question we want to be asked by the service providers, in the 988 calls?
Just having that knowledge to share this as a resource, that this is a place for someone to go and get that empathy, that care, that genuine regard for you as a human being in a safe environment for 10 days to really subside a crisis, prior to going into an emergency room and potentially being held for 6 days, handcuffed to a gurney, not receiving any care, medically, restrained through forced treatment. So really that awareness of what our community resources are, and whether you're from New Jersey or another state, if you're interested in really seeing what a peer-run respite looks like, we have virtual tours on our website that give you an opportunity. So if you don't have one in your community, please be vocal on how valuable these are. we talked about trauma. This is an environment. If it's somebody's first experience with a mental health crisis, we're reducing that level of trauma from the door. And if it's somebody who's been in the system before and received care, we're stopping that trauma from continuing.
Exactly. Thank you. We're trying to offer some of the connecting of the dots here of some simple stop, pause, empathy, know some other awareness, some other resources. What I want to do is bring up one new topic, I guess, that comes from a participant. And it is part of what came up when I did interview a variety of other spiritual and religious leaders, and that's the mental health of our religious leaders themselves. So if you want to comment on that too, you know, every leader has their own challenge, and pastors and rabbis are not exception. We did have one pastor say to us is that we need to give some mental health respite or retreat to our pastors and rabbis and spiritual leaders as well. So Rabbi Kline, would you want to comment, Reverend Sparks, about their own mental health impacted burnout?
I'll start by saying amen. But as what Reverend Sparks said earlier, you're called to do this stuff, and if you are, then you find the ability to say, I can be in, or I can't be in right now. When my first wife died, the next day, the matriarch of the congregation had back surgery that didn't go well. They needed their rabbi. I couldn't go. And had I, it would have been a disaster for everybody. So yeah, we do need care, but we also need to care, to know when we need care and not just march through it. And that's part of what being called is to be so aware from a place of faith that we know where we can be effective. And Ron, I think you said that beautifully earlier in your original comments tonight.
Reverend Sparks, do you want to comment briefly on that?
We need good people around us to tell us to stop. That know our passion, know our hearts, but at the same time want to make sure we're okay. Having a core group of people around you to make sure that you take time for yourself. I have an associate minister, and my wife tells me you need to go on vacation. For a while, we didn't take much vacation, or we took a couple of days, and now we try to make it a habit of going on someplace. Just so that we can get away. I can take my mind off things. I can shut off the phone, or I can not do emails or some of that. So it's really having, as Rabbi Kline says, knowing ourselves, but also having people around us, because sometimes we have a difficult time saying no, and we have to learn how to say no at times.
Yeah. And that's the other side of, we're saying we want to include you more in mental health calls and care, and now we also want to make sure and support your own mental health. I'm going to just do a quick plug for working with a resource that's called Operation Hope. It offers equine therapy. These kinds of services are also around the country, around the world, but we do have one right here in New Jersey. We are going to combine equine therapy with a day retreat for religious and spiritual leaders, because sometimes you don't need to be talked to or even in a workshop, but you're out with horses, and there's something beautiful and healing to offer that. So we have it in our mind and plans. I'd like you to all think about any other questions and closing comments as I bring Hillary forward. And Hillary has been in our back room. And Brett, I don't see you, but somehow if you know how to get yourself on, we'll bring you forward. Hillary, you are a leader in mental health system, and I want to make sure I don't use the wrong word, transformation, paradigm breaking. But you're also a mother of lived experience. What did you hear tonight that you would like to emphasize, reinforce, feel good about? Are there a few comments you'd like to make?
Well, I'd like to say that what I'm hearing is the state of the human condition, and that everybody is experiencing trauma. Everybody is experiencing distress. Everybody is experiencing these crises. And that my hope would be we get rid of the term mental health. And it's about our well-being. It's about all of our well-being. And I think that if we focus on well-being, we start to have a very different lens on what's possible. And and those that are on the front lines of focusing on people who are really showing us where the breakdowns in our system is. These are amazing pioneers, these individuals who go into hospital and suffer through, like my son has suffered through, because they're showing us where the brokenness is. They're showing us where the cracks are, but they're showing us where the change is really possible. And in listening into all of the different the compassion I felt tonight, the absolute faith in that there are ways that we can find our way out of this dark night of the soul that we are collectively as a society experiencing right now in so many different ways, and that there are people that are there that have the good heart to be able to really, and that's an intelligence. That's an absolute intelligence to know what heart to heart, what's going on in those circumstances, and see past the anger and see past the words and connect soul to soul. And hearing, both the Rabbi and the Reverend talk about that, and Olivia, in your work that you're doing with police, and Heather, what you're doing with respite, and Calvin, your focus, heavy focus on bringing spirituality into the mental health system and understanding it in a different way is fantastic. And my one last piece is about equine therapy. And it isn't about hanging out with horses. It actually is that they are amazing, amazing therapists. They connect to energy to energy. They know where the breakdown in the individual is in an energetic breakdown, and they will do their damnedest to get you down into the deepest depth of what you've been holding back. And once you do, they come over and you get the greatest little nuzzle. Once you've done your work, you get rewarded. It's the most phenomenal. And I think the more that we work with these kinds of beautiful animals and other forms of well-being and recovery and all the different things that are there. But what I heard tonight was that we are on the frontier, and we're on the frontier with people who deeply care on this call, who are deeply committed to finding new answers and to exploring things that are on the unknown right now. So that's what I heard.
Thank you for your backroom support. Hillary, I'm going to take you off just to see if we can get Brett on to close. And I'm just not sure if there's because there's so many people on, but thank you for your support tonight and your closing comments. So if we can find Brett, that would be great. But let's just hear a closing comment. We will do another live event in December, and we'd like to just record your final thought of what you'd like to get across to our audience. So Heather.
Sorry, I had to take myself off unmute. The other morning, bright and early, I was listening in when the World Health Organization shared their new legislative and policy guidelines for transforming mental health care. And the moderator had said, in no other area of healthcare are people expected to receive care that is forced or without their decision. And we have to stop and think about that. And how can we explore these alternatives so individuals are not put in that dehumanizing position to experience more trauma?
Thank you. That's a whole nother topic we can do about how mental health is set aside from all other healthcare instances where there's so much agency and conversation. So thank you for being with us, Heather. I'm going to close you out again to also see if Brett can find his way on, but we'll see you again. And thank you for all the services of CSPNJ.
Thank you. And please, anybody, feel free to come welcome and visit. We're right in downtown Freehold, Reverend Sparks. Would love to see you one day.
Okay.
Okay, thank you. So, Dr. Johnson, would you have a closing comment?
Yeah, I'm honored to be sitting here with all of you, just the forward thinkers. Having faith be a part of this. When we take faith out of things, that's why we're in trouble in the first place. Let's just put it that way. When you bring faith back into things, I think it really shines a light on how we move forward. And I think it really sets the tone on the vision moving forward. And just to have so many brilliant minds sitting here, the prospects in the future are just so bright. I'm honored to be here. And I thank you for a seat at the table again, Janet.
Excellent, excellent. And Dr. Johnson, we will get to the plan of offering an orientation program, AWARE, Are We Aware of Religious Experiences, for your first responders. We're going to do it. We'll put a small piece together and we'll practice, we'll experiment. So you can hold us to that. So,
all right.
Thank you again. We'll
Yes,
see you soon. So, Rabbi Kline, would you do a closing comment? And we're going to talk again way after this.
Yeah. I appreciate that while it happened at the end, something that's really important to distinguish, we talk about mental health versus health. And if we really wanted to destigmatize the whole conversation, we'd be talking about healthcare, not mental health care versus healthcare. And in terms of the faith component, if you go into the ER, everything that happens there gets billed. There's payment for everything. There is no payment for calling clergy in. So there is, part of the problem is the acumen and awareness of the institution to even think about calling us, because we don't add to their financial bottom line. Which is part of the healthcare crisis, because we deal with dollar bottom lines and not really taking care of our patient. So I don't know what the situation with 988 is, but does the EMT get the same dollars for delivering to a respite center as delivering to a hospital? And so there's the dollar that drives part of this conversation as well. And in part because we think of healthcare as different from mental health care. It's a complete separate entity. And I think that's tragic, and for future conversation.
I'm putting this in the comments here just to have it recorded. It's good. Reverend Sparks, would you have a closing comment?
I just want to say thank you for including me with such an impressive panel. Always good to see my friend, Rabbi Marc Kline. I was in Harrisburg 10 years ago, and now he's there. And so I know that they're in good hands. One of the things that he said is we got to stop talking about religion and really talk about faith. And I think one of the things that is going to determine faith leaders is, am I going to talk about my faith, or am I going to act out my faith? And when we're able to act out our faith, we will be passionate, have compassion, empathy, because that's what we're called to do.
Amen, amen, amen.
And Echo, I want to thank everyone. This has been a wonderful, and I'm honored to have been included. And Ron, the opportunity to reconnect, we need to do more of this in person.
Excellent. Rabbi Kline and Reverend Sparks, I'm going to just put you in the back room for a moment and would like to chat with you when we close. But as we start to close, and I'll ask Dr. Chatlos to do some summary comments, November 2nd, many of us are going to Rutgers University Medical School. There is a conference, Urban Mental Health, that really brings the medical, therapeutic, and spiritual part of mental health together. Reverend Sparks and Rabbi Kline, you said you'll join us. You will be among the first that really sign up from Clergy. We're looking for more clergy in New Jersey to come to this. And we're also looking for Rutgers to set the stage for other colleges around the country to include faith-based leaders with the medical staff. So we'll just put you in the back room and hold on as Dr. Chatlos wraps up some comments. So, oops, I lost you. Okay, Dr. Chatlos, this is your second time on this with 988, and we're about to do some conferences going forward, including the November 2nd at Rutgers, where we bring medical and spirituality together. What would be your closing comment for tonight?
Well, let me that conference is about religion and mental health. So it really is aimed not just at spirituality, but the faith communities. In thinking about closing comments, let me just say a few. Just to clarify, 988 is designed for the point of intervention after the safety issues are settled.
Mm-hmm.
If police are needed, fine. If an ambulance is needed, if they need to go to an ER, now the safety is there. There are several things that I would urge any of the workers. Number one, first, do no harm. Second, ask yourself the question, aware. Are we aware of religious experience? Take 2 seconds. Then be with that person open-minded, open-hearted, and open-handed, because that person's experience is not yours. Leave your life outside of there. Why? Because the Chinese has, you've heard it before, probably, the Chinese pictograph for crisis is 2 characters. One implies danger, the other implies opportunity. And if we look at that moment with a true faith and spiritual attitude, that moment, that person, us as a professional, we are meant to be there. Everything is as it is meant to be. Where is the opportunity for that person's growth, for that person's transformation, and maybe for you to make a heart-to-heart connection and really help with some real healing? And I think that's really the opportunity of 988.
Excellent. Thank you.
What a great group of panelists. I really enjoy. As a psychiatrist, I'm heartened to hear the interest, the experience, and the thought that you have already put into this. I think it will make it more likely that me and other psychiatrists can actually make a difference in the field.
Excellent. Yes.
And hopefully keep going, and more opportunity and less harm.
The conversation will continue. I'm just going to post this report that was reissued in September by Jim Gottstein and colleagues. There's a whole long list of colleagues that were part of this. And it is on at least Jim Gottstein's psychrights.org website. And there's a few pieces. They highlight, to improve patient outcomes, they boiled it down to people, place, and purpose. To have the right people around you makes a difference in mental health outcomes. Place, where you are put, whether that's in a peer respite, a hospital, or sent home, the place has a whole lot to do with it. And we're trying to wake up and offer better places. And then purpose, they define it as work or school or meaningful engagement. And sometimes that last piece is what's taken away when somebody's locked away in a hospital. And so we're looking to dive into this report on improving mental health outcomes, because there's such great detail in there about peer respite, about peer support, and about many of the things we spoke about tonight. So Dr. Chatlos, I am thankful that you are a strong partner on this, on our documentary. We invite any other clergy, lived experience, therapists, psychiatrists, medical doctors to join in. And if Hillary, if you can put my email up there, you can contact me and find out what else we're doing with conferences, documentary, and raising awareness in our state and around the country. So I think that's it for tonight. My Calvin, if you wanted to say anything while I'm typing my my email in. Do you have anything else to say? I can't get my email in there fast enough.
I just think we are trying to make a difference. Anyone that has this at heart, either from the mental health piece, from the faith piece, from the spiritual piece, please let us know your interest and see if you can be part of what we really hope is a transformation.
So here's my email. You can contact me there, and thank you all.
Bye.
Bye. Bye for now. See you soon.